नहीं ठीक है. Good afternoon, everybody. So we've had a very nice surgical session in the morning with a variety of cases to demonstrate the nuances of Sialendoscopy, and we've deliberately had the lectures post on salivary gland and salivation post our lunch break. So in the morning itself, you noticed when Dr. Milind was operating that he was highlighting the fact that this is a new, relatively new form of treatment modality, and the goal is to leave a physiologically intact gland for the patient. And why not? Because in spite of us having major and minor salivary glands, the total amount of saliva that is secreted in a day is a max of 1.5 liters. And who will understand the importance of lubrication, saliva, is a person who has a dry mouth. So you can imagine what kind of problems that they would be facing. So besides the lubrication for speech, saliva helps in swallowing, mastication. It has digestive properties and antibacterial immunological properties. So what goes wrong? So if there is a decrease in the production of saliva, if there is a concentration of saliva or a stasis of saliva, so all this with a nidus can result in a stone formation, which superadded bacterial or associated bacterial infection, if it creeps into the gland, can lead to salivary gland pathology. So what has been the etiology of sialolis? So all the factors that I enumerated, conditions which lead to a salivary stagnation with a nidus or a matrix, as it's called, for the stone formation. So some metabolic mechanism, some changes take place, and there is precipitation of the salivary salts into this matrix in the presence of inflammation, and this finally leads to a stone formation. And the long tortuous duct situated at a level lower than the orifice doesn't help matters, and that increases the salivary stagnation and an increased chance for calculus formation. So calculi have been there since times immemorial, and so far it always used to be till the last probably 2.5 decades an external approach for the management. But in the 90s, that's where the endoscopy of the salivary glands came into vogue. So we had the flexible mini endoscope developed by Katz, and at the same time Konigsberger, he also was working with the endoscope, and he introduced the intracorporeal lithotripsy. So it goes back to those days. And then Nalili in 1994 had started work on sialendoscopy and has had extensive works, large number of publications by him, and of course the well-known name Marshall in 1995. And then there has been gradual improvement in technology and techniques over the years, from the newer and newer instrumentation to where it is today. So the question in everybody's mind before all this started was, why sialendoscopy? So as has been highlighted in the morning, that it is an organ preservation surgery, and if you have an organ which has a normal function, why should you be sacrificing that organ? So the most important thing one needs to realize, that the pathology may be affecting that organ, but physiologically that organ is doing well. So that is why you should try and save and salvage that particular organ. It's a relatively minimally invasive technique in majority of the cases, and hence will have a lower morbidity. You're going through the normal opening, so a very cosmetic procedure. And since morbidity is low, there is almost an immediate return to normal activity. Within a couple of days, the patient can go back to work, unlike when you are using an external approach. And of course, if you are using the natural orifices, then you are avoiding all the complications of an open surgical approach. So today, pretty much you can cover all, it can be used for the diagnosis and treatment of almost all obstructive salivary gland disorders. Of course, the caveat being you need to have the instruments to be able to then tackle that obstruction. So what then are the indications? So as I said earlier, it can be used for a diagnosis for any obstructive salivary gland pathology. Generally, of course, we're talking in terms of the major salivary glands, the parotid and the submandibular. And it can be used for a plethora, a variety of therapeutic indications, of which by far the commonest is salivary stone, sialethiasis, and for patients where there are recurrent acute or a chronic sialadenitis. It can be used for cases of stricture stenosis in the duct. So we had one case in the morning where Dr. Milind demonstrated how we can tackle duct stenosis and strictures. Post-radiotherapy dryness of the mouth. So these patients at the right stage can be helped with a therapeutic endoscopy. In Sjogren's syndrome, again the same pathology, you can flood the glands with steroids and help these patients to some extent. Very rarely you have foreign bodies in the duct which can be accessed via sialendoscopy, and again rarely ductal neoplasms which can also be biopsied through this. Coming to children, more or less similar indications, so recurrent sialadenitis, chronic sialadenitis, stones not so common in children, strictures, stenosis of the submandibular or the parotid duct. But one very important indication is juvenile recurrent parotitis, and this is something that we need to understand. Not a very, very common problem, but when it happens to a particular child, it's quite distressing, not only to the child but to the parents. So this is basically a non-specific sialadenitis with recurrent inflammation in children. And after mumps, it is probably the most common cause of parotid swelling in children. And cause is really not known, but there is decreased salivation, insufficient salivary outflow, and ascending infection via the oral cavity. So all this leads to a situation where the child develops swelling, pain associated with fever. Quite often it is ductal wall, bleeding is very high. So you should put these patients on antibiotics and then control the acute infection and then go ahead. Sometimes if there is a very narrow duct or if there is a complete distal duct obstruction, so where you just cannot negotiate the duct. So, and as we mentioned in the morning, that distal is in terms of the gland parenchyma and proximal and distal. So these cases you will not be able to do too much. And trismus, of course, you cannot open the mouth, so you are not going to be able to do the procedure. So there are limitations to this procedure. So what I mentioned earlier, so if there are multiple strictures or recurrent strictures, then you may not be able to do too much for these patients. If there are very large or impacted stones, so if there are large stones, so today as Milind demonstrated, you can break these stones into smaller pieces and then remove them with the help of your burrs or your holmium laser, or of course lithotripsy. But if they are very impacted, then you cannot do much endoscopically in some cases. If there is a generalized narrowing of the complete duct, then again you will not be able to do much. And if the stone in some cases where it is in the very, very proximal portion, or in the gland parenchyma itself, then just purely by sialendoscopy you may not be able to access that. So what do we do? In these cases, a combined approach is what is advisable in a large number of these cases. So if the stones are in the secondary ducts, if you've got a large stone near the hilum or in the proximal part of the duct, you can, or if there's an intraparenchymal, so you can do a combined approach, whether you do it with lithotripsy, whether you do it with an external approach, and of course if there is a very large impacted immobile stone. So every surgery comes with its complications, and which I will just briefly mention, because Dr. Milind will be talking on that a little more in detail. So the minor complications are bleeding, which you saw how it can be very easily managed. Sometimes not very common, but yes, it can happen. One very common thing that happens is a temporary swelling, because we saw how we are irrigating the duct, and at that time you can land up with a temporary swelling which will just settle down just with anti-inflammatories and a little massage. If the mouth has to be kept open for long, sometimes these patients can get a TM joint strain, and occasionally you can land up with a perforation of the duct wall, but if identified in time, then it's not a major complication. So what are the major complications? So degloving or avulsion. So if you are trying to remove a stone and you land up stripping off the entire lining of the duct, that becomes a major complication, because sure enough you will land up with a stricture because of that. Breakage of the instruments, which besides being a major complication for the patient, it's a major problem for your wallet as well. Neural damage, so you can get lingual nerve paresthesias, stricture formation and ranula formation. So these are the major complications. Brief mention, the lithotripsy can be by the intracorporeal of salivary gland disease. So when we see a patient with a salivary gland disease, so what do? We get an ultrasound done. If there is an obstruction, you can, as we mentioned earlier, do a diagnostic sialendoscopy. So if it is for stones, you do an interventional sialendoscopy. If there is inflammation, you do again interventional sialendoscopy, cortisone instillation. In some cases, if there is a stricture, again you do the sialendoscopy plus or minus putting in a stent with cortisone instillation. And of course, if there's any other indication for obstruction, foreign bodies, you can go ahead and remove that. But if in spite of all this, if there is a persistent symptomatic obstruction, then you have a variety of options. So you can do your extracorporeal lithotripsy, which unfortunately is not really available in our country. Transoral duct slitting, you have other operative in duct interventions with or without stenting, or you can always do the combined approach where you have the endoscopic and a transcutaneous approach, again with or without stenting. And only if you have failed with all these measures, then you would be justified in going ahead with a gland excision. So if you have a case of calculi stones in the glands, then you can follow this algorithm, which is based on the size of the stones. So if there's a recurrent glandular swelling, small stones less than 3 mm in the parotid, less than 4 mm in the submandibular, probably we can extend it to 5. You can remove this endoscopically with the help of a basket or a forceps. If they are larger stones, up to the size of 6 to 7 mm, then you may need to do a fragmentation, either using the laser or with mechanical tools, with or without basket removal, or sometimes you may need to go in for a combined approach. And if it's a large stone, larger than a 6 to 7 mm, then in most of these cases, if you are not able to fragment, combined approach. Now, depending upon the location of the stone, a large stone, larger than a 6 to 7 mm, then in most of these cases, if you are not able to fragment combined approach. Now, depending upon the location of the stone, visible, again try to slit open the duct and remove that, but if it is impacted and not palpable and not visible, then you need to do a lithotripsy and then try, if it comes out with that, fine, otherwise you can then go ahead and do an endoscopy. And once again, if you are not able to get it out and it's symptomatic, then you need to go ahead with the removal of the gland. Similarly, for parotid stones, a similar philosophy. So if it is mobile and of adequate size, then you can remove it with the endoscope, or breaking it in size with the lithotripsy and then removing that with or without a combined approach. If it is in the proximal part of the duct, then a lot of these cases you may not be able to remove it only with the endoscopy. You will need additional measures to reduce the size, or you will need to combine it with a endoscopic and transcutaneous approach. And if it is parenchymal and impacted, then yes, you need to break the stone and then only retrieve it with the endoscopy and not the other way around. And if the gland, if the stone doesn't come out and it's a symptomatic patient, then you may finally be forced to do the gland extirpation. For submandibular gland and more or less for strictures of both the parotid as well as submandibular gland, depending upon whether it is inflammatory or fibrous, you may want to do the interventional sialendoscopy with cortisone injection. If required, you may do a transoral duct slitting. If it is in the proximal portion, again depending upon the pathology, in most cases you will be able to instill cortisone hydrocort over there, and endoscopically, if required, do the transoral slitting. If it is intraparenchymal, then those are difficult cases where you are not able to see the fibrosis. Then you try and inject some cortisone and hope that it works, and if it doesn't, then in those cases, you and a symptomatic patient, you may need to go ahead and remove the gland. Now, sometimes if you have not been able to remove a stone with lithotripsy and there is a residual stone, then in these cases, if it is symptomatic, remove that. If it is not palpable but symptomatic, then you may need to go ahead and remove the gland itself. But if it is we sometimes come across cases where there is a difficulty. So you need a very specialized training to be able to, before you can start doing these cases. It involves a lot of costly equipment and accessories. So this slide shows you pretty much that you cannot do with one scope or with one instrument. You need a plethora of instruments, because if you are committed to doing a diagnostic, then you should be committed towards doing a therapeutic removal also. The other problem is that the cases are few and far between, so you need to know what all your indications are, and then counsel your patients accordingly, and probably with more and more experience, one will be able to do more and more cases. And one very important thing is that you cannot keep a very rigid timeline for this particular surgery. So if it's diagnostic, yes, but if it is a therapeutic one, it can take you anything ranging from 1 hour to maybe 3.5, 4. Milind will bear me out as to what is the longest that he has spent in one particular patient. So with this brief introduction and why we should be doing Sialendoscopy,
Thank you, sir, for a wonderful presentation. In the end,